Hi, good morning, and thank you for having me. So today I was asked to talk about the knee. So sort of examination, diagnosis, and treatment options. So I'm hoping today you'll kind of get a little insight into how I approach the patients, kind of looking at obviously risk factors, looking at them as a whole. So what they may be doing that's causing the pain, making it worse, looking at their mechanics to kind of get to the root of the problem and not just treating symptoms. So I have no disclosures. This is going to be what we're going to talk about today. So we're going to start off kind of going over history and physical, differentials, imaging, how to treat the knee, and then when to refer the patient out. So these are the objectives for today's lectures. I'm hoping that you'll be able to describe some clinical features and physical exam findings for common knee pathologies, when to order imaging, sort of what management strategies there are for the knees, focusing on exercise, patient education, and injections, and then reviewing the indications for specialty referral. So just to start off, just as a quick review of knee pathology so that when you're going in to target the patient, you kind of know what you're looking at. So anteriorly, we have our bony landmarks. We have the fibular head. We have the tibial tuberosity here. Medially, we always remember the MCL coming across the joint, the meniscus right there in the medial joint. And then we also have the equivalent laterally. So the lateral meniscus, the lateral LCL. And then we've got our two cruciate ligaments, our stabilizers, our knee stabilizers kind of crossing in the midline. And then obviously the entire joint is lined with hyaline cartilage. The muscular attachments around the knee are also important. Any imbalance in the musculature, tightness, weakness, can obviously lead to poor tracking and poor knee stabilization. So just remembering that we have our quadricep tendon coming down to the superior aspect of the patella. We have the patellar ligament coming down, the patellar tendon coming down and attaching on the inferior pole. We have our patellar retinaculum, the iliotibial band that comes down onto Gerdy's tubercle. And then we obviously have our hamstrings that come down here, biceps, the semitendinosus, semimembranosus gracilis that comes and attached to the pes. All right. And then this is the posterior view. So looking from behind the patient, we still have, the two menisci that are quite present laterally as well as throughout. We're going to take a superior view also, and I'll show you the meniscus more clearly. And then this is our collateral ligaments in the middle, or sorry, our cruciate ligaments in the middle here. And then looking at all of the different, muscle and tendon attachments posteriorly. So very complex in the posterior knee. So posterior knee pain definitely can be something that is hard to treat. We're always thinking, Baker cyst, which certainly is in the medial aspects, usually right here. Between the gastroc tendon and the seminosus tendon. That's usually where it arises. But we can also be having popliteus pain. We could be having gastroc, origin pain, or even sometimes hamstring insertional pain. So just to keep in mind how complex it is, to not be forgetting, any of the other possible pain generators. And then this is sort of a superior view, top down. And so we have our menisci, which are two kind of horseshoes. And so when we're thinking about meniscal injuries, it's important to know kind of where the damage is, because that's going to determine how well it is to heal and what the options are surgically. Oh, sorry, I went back. There we go. So, there's blood supply, kind of around the periphery. As we go deeper, there's less and less. And so, a far distal tear, as long as it's not flapping, usually does not need to be acted on. Anything that's more kind of posterior and going through, there's risk of, it flapping into the joint and causing mechanical symptoms. So something we're always keeping in mind when we are examining our patient, but also getting a history to see what kind of symptoms are the result of what we're seeing on potential imaging. All right, so gathering information, history taking, what are the first things we want to ask? So obviously demographics and then potential risk factors. So finding out their age, their biological sex, risk factors such as prior injuries, family history of osteoarthritis, or maybe a rheumatological condition, what their occupation is, their athletic activities. So getting a sense of how active the patient are. Have they been hard on their knees? Were they a football player? Did they injure their knee in high school? And then obviously knowing that something like osteoarthritis, which is probably the most common knee injury we're seeing in our middle-aged population coming in, over the age of 45, older adults, with obesity, it's more common. So getting a weight, getting a height, checking the BMI, and then previous trauma. So post-traumatic osteoarthritis may be presenting in someone much younger than you would expect. So getting that good history of any past injuries is important. And then pain characteristics. Was this acute? Did it come on suddenly? Was it insidious? So like they'll say like, well, it started 3, 4 years ago and has slowly been creeping on. How long has it been going on for? Is this something that's been affecting them for a few weeks, a few months, trying to understand the chronicity of it? And then the progression, did it start a few years ago, wax and waned, but now it's more consistent, or has it just been building up over time? Getting a sense of where it is. So is it more medial joint line or lateral? Is it right over the patella? Is it in the popliteal fossa? And then the quality. So, is it sharp and stabbing? Is it more of a dull kind of toothache? All of these questions kind of help pinpoint, to some kind of injury. So obviously an acute, sharp, pain that happened, with a twisting motion leads us more to think of an acute injury versus something that's insidious, achy, stiff, that's been creeping on for years may point more towards a degenerative cause for their pain. And then noting if it gets worse with activity, if it's relieved by rest, is it present at night? So, something like morning stiffness that goes away pretty quickly, but they're waking up pretty stiff and tight. Um, is suggestive of osteoarthritis. Whereas, if the stiffness persists a lot longer, then you're thinking more of a rheumatological condition. So really clarifying the pain characteristics can really point you in the right direction of a diagnosis. Asking about mechanical and systemic symptoms. So is there locking, popping, clicking, buckling? Does the knee feel like it's giving out? Is there swelling? Does the knee kind of fill up and then go down? Is there instability? Like it feels like the knee is wobbly or it can't bear their weights. And then obviously crepitus. Most patients will say that they feel crunching or cracking. Um, and that's how they'll describe crepitus. So meniscal tears, if they're large enough that it's causing, disruption into the joint movement, often presents with locking or catching, especially after trauma. So, asking about those symptoms can really kind of point you in the direction of a meniscal pathology. Swelling and effusion, is an indicator of an intra-articular pathology. So generally like a quadricep or patellar tendinosis, an MCL strain should not be causing intra-articular swelling or edema. If it's red, hot, swollen, if the patient's complaining of fevers, then obviously in the back of our minds, we're suspicious of an infection or even inflammatory arthritis. If it's swollen and a little warm, but no redness and no systemic symptoms like fevers and chills, may just represent, an effusion in the setting of an intra-articular pathology like a meniscus tear, or even osteoarthritis. Ask about other joints. If they're coming in with knee pain, how are their elbows, their wrists, their hands? Do they get rashes on their face? Do they get rashes on their elbows or their extensor surfaces? Any recent viral illnesses? So anything that may point toward a more systemic cause for their pain. And again, this is where the bigger picture starts to fill in. So if they've had an acute pain with swelling and oh, their kid was sick 3 weeks ago and now they're sick, that's pointing toward more of a post-viral arthropathy versus someone who may have psoriasis their whole life and now they're starting to develop knee pain. You're thinking more of a psoriatic arthritis. And then asking how it's affecting their impact. So, are they able to perform their ADLs? Are they able to work? Are they able to do their hobbies? Most patients will say that they have a limitation of movement from osteoarthritis, and most will say that it significantly impacts their ability to perform things of daily living. So getting in and out of the tub, standing to wash, dishes, going to the grocery store. And then, trying to document trauma or a precipitating event, especially if this is a work-related injury. You want to be clear on method of injury. So were they bending and lifting? Were they twisting? Was there a fall? It can point, mechanism of injury can also help point towards a diagnosis. But also if it was a trauma, that will kind of push you to get imaging sooner rather than later. So gathering all this information really helps narrow down the diagnosis, but then also asking, what have you tried? So, have you done physical therapy before? Have you been trying medications? If so, what and how often? Patients will tell me Tylenol doesn't work. They're taking it once a week. So it may not be that they're taking enough. They tried one Advil, it didn't help, so they swore off NSAIDs. It may be that it was the wrong dose or the wrong kind of medication. So probing in terms of actually how they're taking it is important because it just may not be the right dosing or the right medicine for them. If they've done physical therapy, I always ask, what did you do? If they were sitting in a room with a hot pack, a TENS machine, and then told to go do exercise in the corner, it just may not have been good physical therapy. So trying to probe on, what treatments they got, what that looked like, and then how they responded. And same with injections. Some patients don't know what was injected, but if you can clarify, was it a steroid? Was it a gel? How many did you get? And how long did it help for? That will help determine the next steps in management so that you're not reinventing the wheel, but you have an idea of what worked and what did not. And then again, looking at the bigger picture, and I sort of alluded to this on the previous slide of, what else could be contributing? So, do they have a history of gout? Do they have, diabetes or cardiovascular disease? Do they have peripheral arterial disease? So their leg pain is really claudication. Do they have peripheral neuropathy? And so their gait is imbalanced, and that's, making the knee pain worse. So looking at them as a whole of what else could be, worsening their pain or causing it to begin with. And then obviously red flags. So this is where immediate, referral to a specialist or even the emergency room is warranted. And it's really, with knee pain, it's the biggest red flag is really obviously a septic joint. And so a reason for infection, a recent injection, a recent, any kind of puncture to the skin, whether that is trauma, um, or if they've had a recent viral illness, if they're an IV drug user, anyone who may be at risk of bacteremia certainly could be at risk of a septic joint. If they've had hardware in there, that increases the risk even more. If they've had like recent dental procedure, anything that can cause bacteremia essentially could cause seeding into the knee joint. So if they have night sweats, chills, pain at night, rapid progression of swelling and erythema, you're certainly thinking infection. If it was a little bit less acute, you could be thinking malignancy or an inflammatory process. Gout in the knee can show up as like red hot swollen joint as well. And this is where aspirating it immediately, sending it for culture is important. You can get an idea quite quickly if you're looking at an inflammatory joint or a septic joint. So physical exam, look at the patient, look at the knees. I usually get them in shorts and have them take off their shoes and socks because I want to look at where their knees are facing, what their feet and ankle are doing. Are their feet out? Are their feet pointing in? Are they flat-footed? Are the kneecaps off to the side? And then you're looking for asymmetry, swelling, bony deformities, redness, erythema. And then you're going to palpate what hurts. And a lot of times they might have diffuse tenderness, especially in the setting of osteoarthritis, or if they have an effusion, they can be tender quite all over the place. So you're going to be, kind of palpating over the bony prominences, looking for an effusion, palpating over the tendons, range of motion. So get a baseline of normal. So, check their hips, check their knees, and do it on both sides. Because if patient is hypermobile, you may think that is a joint, that joint is lax, but it actually just may be normal for them because they have a mobile joint. If they're really stiff and that knee is not getting all the way into extension, they just may have tight hamstrings. So testing the other side and testing the hip as a comparison kind of gives you a baseline. I usually do a very basic rudimentary kind of neuro screen on these patients just to make sure I'm not missing another cause for their pain. If the patient has really bad peripheral neuropathy, like I said before, that could be affecting the knees. If they have a lumbar radiculopathy, that sometimes can refer to the knee as well. So just making sure that I'm ruling out everything by doing a quick basic neuro exam and then obviously special tests to try and hone in on what is causing the pain in the knee itself. So the basic neuro exam, I test L1 through S1 with hip flexion, then knee extension, dorsiflexion, EHL extension, and ankle plantar flexion. So again, I just rate them 0 to 5 for each muscle group, and this can be done quickly, with the patient seated. So 0 is no muscle contraction at all. 1 is a flicker. 2 is there's some movement, but with gravity eliminated. 3 is they're able to, let's say extend their knee against gravity, but you're not putting any resistance. Adding a little resistance would get you a 4, and then obviously full strength would get you a 5. And this is where testing both sides is important, because the patient just may be weak. If they're debilitated, if they have sarcopenia, if pain is limiting what they can do, it may not be a neurological deficit. It may just be submaximal, effort for lots of different reasons. Sensation, I'll usually at least do light touch. Sometimes I'll do pinprick if I am suspicious for a neurological condition. Sometimes I'll take like a pipe cleaner and I'll use like the soft part, and then I'll use the sharp end to kind of check both light touch and pinprick. And this is a dermatomal map. I just try and hit all the relevant dermatomes in the lower extremity. So certainly you can see that L3, 4, and L5 do cross the knee medially, anteriorly, and laterally. And I have seen, radiculopathies where the patient has gotten knee injection after knee injection that don't help. And it's really because it's referred pain, from a radiculitis. And then I check for reflexes. Anytime someone's in the office, it's good to check just to make sure you're not missing, anything that's going on. And I do them bilaterally just to see if there is asymmetry. Patella is L4 heavily weighted and the Achilles is S1. So certainly the patella reflex is a good one to do if you have any suspicion that there may be a radicular component causing their knee pain. Babinski will check for upper motor neuron signs. If there's any gait pathology that you're worried about that may be contributing to the knee pain, you definitely want to be ruling out hyper or hyporeflexia, from a cervical myelopathy or something as such. And then proprioception, I'll usually check the big toe. All right. So with observation, like I said, I have them standing, I have them in shorts, I have their shoes and socks off. So you're looking for alignment. So, varus deformity is very common in individuals who have advanced stage osteoarthritis. Valgus deformity, or even just valgus maltracking with squatting, is really common with patients with patellofemoral syndrome. It's actually a risk factor for patellofemoral syndrome. So a lot of times I'll have them stand facing me. I'm looking to see if they're rolling in with their feet. If they have flat feet, if they have pes planus, that will put them at risk of patellar maltracking. And then I'll usually say, just bend your knees, do a little squat, doesn't have to be a full squat, and just see what's happening with their legs. Are they going into varus? Are they going into valgus? And that gives you a great idea of why they may be having some knee pain. Because if they're not in a good alignment with bending their knees, every time they're going up and down stairs, getting up from a seated position, they're putting, pressure over that patellofemoral compartment. And then palpation. So obviously over the joint lines, over the patella, over the tendons. You want to check, the pes anserine bursa as well, where you have, the semimembranosus, semitendinosus, and gracilis coming and attaching. Feeling through the popliteal fossa. So obviously feeling for a Baker cyst, which is usually more medially, but then also palpating the insertional tendons of the hamstrings and the origin tendons of the gastroc, gastrocnemius. And then over the bony, tibial tuberosity and the fibular head. The IT band, where it comes down and attaches, over Gertie's tubercle, can also be a source of pain. So trying to locate, the pain by palpation will often kind of guide you in the right direction. And then range of motion. So, most patients should be able to flex their knee quite far, certainly past 90, 135 degrees is considered normal. Extension to 0, is ideal, but again, compare sides. If patients have difficulty, with range of motion, it may not just be from that knee. It may be due to, like I said, hypermobility or contractures from a greater systemic issue. And then I'm going to go over special tests. So before I do that, I'm just going to kind of remind everyone about sensitivity and specificity. We have a lot of special tests for the knee, and they're not all great tests. So this is where taking the bigger clinical context, your history, finding about what kind, like the character of the pain, the mechanical symptoms, The chronicity of the pain is also helpful because these tests are not perfect. So if a test has high sensitivity, it's really good at ruling out a disease. So if, you do a meniscal test and it's negative, there's a good chance they don't have a meniscal tear. For a test that's very specific, it's good at ruling in. So if it is positive, there's a high chance that they have it. So I've put in parentheses the sensitivity and the specificity of each test, and you can see that they're not great. And for some of them, we don't even have good data on it. And so I include it just to kind of show you that, the special tests in and of themselves are not standalone. You need a good history, a good physical exam, in addition to the test to really clarify a diagnosis. So obviously, a meniscal injury. Someone comes in, they're playing basketball, they landed, they twisted, they had sharp pain over the medial knee. They've got some clicking and cracking. It was quite swollen for a few days, and now they feel like the knee is buckling going downstairs. So you already have a good picture. So you're thinking meniscus injury, you're going in for the tests. So the first test we usually do, is a McMurray test. And so this is where you're testing, you're kind of, usually you have your hand over the medial and then the lateral joint line. And you kind of bring the knee into flexion and extension while putting varus and valgus stress on it. So kind of internally rotating the leg and straightening it really tests that lateral knee, and then going externally and then straightening the knee will give you more stress over the medial knee. So pain, suggests that there is no meniscal tear. So this is a very specific test. So if they have pain, if it's positive, there's a good chance that it is really a meniscal tear. If it's negative, though, it's low sensitivity. So you just may not be putting the right direct pressure on it to catch it. So a negative test does not suggest no meniscus tear. Next is the Apley's test. And this one, you have the patient laying down with their knee bent to 90 degrees and their foot's kind of completely flexed. And the first part is you sort of distract it. So you're actually taking the pressure kind of off the knee joint. So you're alleviating the pressure with distraction, and that should feel better because if there is a meniscus tear, you're no longer compressing it. And then you're actually pushing and grinding. And so you're compressing that knee joint. If there's a meniscus tear, you're basically squishing it. So pretty good, specificity. If there's pain, there's a good chance that there's a meniscal tear, but it's not that sensitive. A lot of times patients, this does not actually aggravate their pain depending on where the tear is in the knee joint. So then the last test we do to kind of confirm meniscal tear is Thessaly. And this one's a little bit harder. You need patients who have pretty good balance, who can stand on one foot. So even my little old ladies, I'll do them and I'll hold their hands and I'll be twisting them for them. My young, soccer players, I have them just do this on their own. And this is quite sensitive and specific. So if you have a meniscal tear, this usually will be painful, and really will re-aggravate, wherever the tear is. The next is looking at patellofemoral syndrome. So again, someone might come in and say, oh, I have pain, walking downstairs, just like on the anterior part of my knee. It feels like there's grinding, some stiffness in the morning. If I sit for too long watching a movie and I get up, my front of my knees are really tight and sore. So I'm already thinking patella. I should have observed already, in my observation section, how those kneecaps are tracking. So do they have flat feet? Do the kneecaps point outwards? Do they point inwards? When I had them kind of do that initial little squat, were they going into valgus or varus? Was there poor patellar tracking? The grind test really just reaffirms that there's pain kind of around the patella and then in that patellofemoral joint space. So you get your thumbs up and under the inferior patellar facet, kind of around the patellar tendon, and you apply pressure. And then you continue to apply pressure as they go into extension. So as they're straightening the knee and the patella moves, you're kind of moving along with it and applying kind of upward and downward pressure, and you're basically grinding the patella down into the joint space. And this will reproduce pain, a lot of times crunching, clicking as well, if they have patellofemoral syndrome. Obviously, next you're looking at ACL and PCL pathology. This is usually more of the patient will have a history of trauma. So they'll say, I was skiing and I fell, I was playing basketball, my leg gave out. And so rarely is this an insidious kind of pathology. Usually the patient will report instability, the leg giving out, buckling. Usually, if it's after the acute event, there'll be a lot of swelling in the knee. So that's very common. If you see them very soon after and the knee is still edematous, sometimes anterior drawer and Lockman will be negative. You won't be able to elicit any instability because there's just too much edema to actually move it. There's also the difficulty of pain. If the patient just had the trauma and they're still in a lot of pain, they're going to be guarding. So they're going to be preventing you from moving it. So getting a sense of what normal is. So I usually do this on their non-affected side first. This is what I'm going to be doing. This is where my hands are going. Trying to calm them down so that they don't guard is important. And then going to the pathological side and trying. So anterior drawer test is a little bit easier to do. I usually kind of sit on their foot to stabilize, and then you're just trying to translate the tibia kind of forward over the femoral condyles. This is easier in your larger patients and your frail patients versus the Lockman test, where you're actually holding, the femur and then holding the tibia and you're trying to distract. This is hard to do if you can't get your hand really around the patient. I do sumo coverage on the weekends. I cannot get my hands around the sumo wrestler's legs. So I strictly use the anterior drawer sign, which is not as sensitive, but in the cases where I'm not able to do a Lockman's, that's what I use. And a little translation is normal. That's why testing the other side is important to kind of get a baseline. And they'll say like at least a 5 millimeter translation. Again, it's very patient dependent. If there's edema, if there's guarding, if they're hypermobile at baseline, 5 millimeters is not a cutoff that I'm really using or hanging my hat on. Next is PCL laxity. So most common one is just looking for basically posterior translation of the tibia on the femur. So if you get them kind of laying down, get that leg up, just sort of support their ankle, the tibia is going to kind of bow in right here. You're going to see that that bowing right where the tibia is supposed to articulate with the femur. You can also do a posterior drawer. So very similar. You have them sitting, you're stabilizing that foot, and you're sort of pushing backwards now, and you're translating that tibia posteriorly over the femur. Again, test the alternative side because, or the other side, because if the patient has movement, they may just be lax. So comparing them is important. And lastly, collateral ligament. Laxity or strain. Pain over the medial lateral joint line is usually joint line pathology, but it can also be ligamentous pathology. And so testing, with varus stress, will elucidate any kind of laxity or pain over uh, the lateral meniscus, and then valgus stress, obviously over the medial meniscus. And so compare it to the other side to see if they're lax. If there's a lot of pain and guarding, you may not get laxity, but you would be reproducing their symptoms. So pain also could just be an indicator, even without the laxity. So those are sort of the core sort of special tests that I go through to again, sort of narrow down what's going on in the knee. So usually from there, I'll kind of come up with my differential diagnosis, and then I'll see, if imaging or anything else is warranted, to kind of narrow it down before I come up with a treatment plan. So most commonly, is osteoarthritis, especially in our middle-aged patients with insidious, sort of onset of chronic pain, stiffness. Osteoarthritis is usually, what we're looking at. Meniscus injury is usually after trauma, but that being said, degenerative meniscal pathology is very common with moderate to severe osteoarthritis. So if the patient has had osteoarthritis for a while and the treatments that used to be working are now not, and some of the meniscal tests were positive, they may have a degenerative meniscal tear, which is common to see in more advanced osteoarthritis. Patellofemoral syndrome is sort of a continuum. So this really just describes any pain kind of in that patellofemoral compartment or space kind of anteriorly. It starts really just with maltracking. So if that kneecap is not moving in its groove, every time you flex and extend, it can cause pain without any actual bony cartilage or ligamentous injury. It can then progress sometimes to quadriceps tendinosis, chondromalacia patella, where you start to get wear and tear of the hyaline cartilage under the kneecap, and then obviously advances to osteoarthritis of that patellofemoral joint. So it is a continuum from just poor tracking to arthritis. And so obviously identifying it early, treating, the cause of the pathology, whether it's, pes planus, a tight IT band, weak hip girdle that's causing them to kind of go into valgus. Treating the cause is important to identify it early. Ligamentous injury. So again, if there's laxity, that's obviously going to kind of make you think about um, ligament involvement. And again, usually there'll be a history of trauma. Very rarely do we see degenerative, ligamentous injury. Sometimes we can start to see mucoid degeneration of the ACL in a knee with severe osteoarthritis. But again, this would be more of an insidious onset over time. Bursitis, so pes answering bursitis, kind of in that inferior medial aspect of the knee. Patellar bursitis, so this usually has some kind of trauma over the patella. It's very superficial, just on top. That can also swell up quite large, with usually like a fall onto the kneecap itself. And then tendinopathy, most commonly it's patellar or quadricep tendon. But if they're having posterior knee pain, remembering about the hamstrings, as well as the gastrocnemius tendons that start behind the knee, and then iliotibial band syndrome. So that can also cause lateral knee pain as well. Things you don't want to miss, obviously, is a septic joint. That's an emergency and needs to be treated with IV antibiotics. So if there's a red, hot, swollen joint and the patient has any systemic, symptoms, aspirating, sending it off. And if you have any, true concerns, sending them really to the emergency room, as this patient does need to be aspirated and then get IV antibiotics quite quickly. And then a tibial plateau fracture. So, a lot of times if patients have kind of chronic arthritis, but then have an acute period where something changes and they get much worse and they have a lot of pain kind of over that tibial plateau, sometimes they can get stress fractures. So it doesn't always have to be an acute fall or trauma. Sometimes just that chronic wear and tear, once they have severe end-stage osteoarthritis, with an acute change in their manifestations of symptoms, it may be bone marrow edema, it may even be a stress fracture line. So things not to miss. Less commonly, but sometimes we'll see it, is, pseudogout, so calcium polyphosphate crystals. Sometimes you'll get an X-ray and you'll see kind of calcifications through the joint line. That is a good sign that the patient has the calcium polyphosphate deposition. Pigmented villonodular synovitis. So, red hot swollen knee, and then you go to aspirate it and nothing but blood comes out. Or you're ultrasounding it and you see this really thick, dense synovium. It's a benign giant cell tumor, and really it presents with hemarthrosis, but in the setting where the patient hasn't had trauma or doesn't have a bleeding disorder. And for this, it usually requires surgery to actually excise the tumor, or else the knee will keep bleeding and then predisposes the patient to articular damage from the blood. Synovial plica syndrome. So these are little plicas that can happen around the patella, usually laterally. It can cause catching and locking. Usually you can kind of feel it. It can be painful, especially if it's causing, catching with extension and flexion. Hoffa's fat pad impingement. So there's a nice big fat pad under the patellar tendon, kind of on either side. So if they have tendinopathy, patellar maltracking, if that patellar tendon is not gliding nicely over the fat pad, it can actually be getting caught. It gets stuck right as they go into an extension. So usually just kind of pinching the fat pad on either side of the patella, having them go through that range. If they have reproduction of pain, not on the patellar tendon itself, but on either side over the fat pad, that's a good sign that it may be getting impinged. And like I said before, an L4 radiculitis can present as knee pain. That L4 dermatome crosses right over the knee. So if you have any suspicion, making sure that your exam includes the back is important. And then hip osteoarthritis can refer down to the knee. So making sure that when you're examining the knee, doing a quick, hip range of motion. Do they have reduced flexion, they have reduced internal rotation, can actually elucidate any hip pathology that may be causing the knee pain. I've seen patients that have been, getting knee injections and not getting better, and then you check the hip, inject the hip, and the knee pain goes away. So it's important to make sure that you're not, going too quick to a diagnosis of knee pain, and missing something else that may be referring the pain to the knee. So this is just a cartoon I like where it says, okay, if this is where the pain is, these may be differential diagnoses. So obviously above the knee, you're thinking quadriceps, could be arthritis, and the VMO gets really sore and tight. It's more like the patella, that it could be bursitis. Anything around the kneecap, of course, you're thinking of the patellofemoral syndrome, which could be anywhere from the maltracking to chondromalacia, and then osteoarthritis. Right below the knee, you're thinking patellar tendonitis, Hoffa's fat pad, impingements. If you're going right over the tibial tuberosity, if they're a young child, Osgood-Schlatters disease. If they're older, any kind of pain or inflammation over the tibial tuberosity would be Sinding-Larsen-Johansson syndrome, which is basically Osgood-Schlatters, but in adults. Um, and then obviously patellar tendonitis is also a possibility. You're feeling over the tibial plateau in case you're concerned about an acute injury or a fracture. Behind the knee, obviously a Baker's cyst or a popliteal cyst is the first thing that comes to mind, but don't forget about the tendons, the hamstring tendons, the gastrocnemius tendons. Um, Meniscus injuries can also be posterior, so feeling along the joint line posteriorly as well, which is important. Medially, arthritis, the MCL, but also plica syndrome can occur, pes anserine bursitis, kind of more anteriorly. And then laterally, your iliotibial band syndrome is really a big one. And again, this is where looking at tracking, feeling that band to see if it's tight is important. And then less commonly, obviously, an LCL injury or lateral tibial plateau fracture, which again is not as common. So you've examined them, you have an idea of what's going on. Before you start your treatment plan, do we need imaging to take the next step? So imaging can be important if you don't know what's happening, or if you need, clarification on the diagnosis, or you're thinking of escalating treatment, or if treatment that you've done has not helped. So, the American College of Radiology really recommends radiographs for sort of acute pain or acute symptoms. So, focal tenderness, an effusion, inability to bear weight. If you're worried about intra-articular pathology that's acute, so a fracture, an ACL tear, an acute meniscus injury, getting a radiograph right away makes sense. Um, that being said, if you suspect the patient has osteoarthritis, they're over 45, they have, 30 minutes of morning stiffness, it's been a chronic kind of ongoing issue, radiographs really are not indicated to just assess joint space. When someone is ready for surgery, usually we go based on symptoms, but if you are planning on sending them for a surgical referral or injections, I usually do recommend radiographs. And that is really because you want to be able to kind of manage expectations and also prognosticate. If someone has early arthritis, some injections may be more appropriate, or some, treatment plans may be more appropriate versus someone who has end-stage osteoarthritis. If they already have osteophyte, sclerosis, loss of joint space, they may be less responsive to conservative management. And so radiographs, if you're planning on changing or escalating care, is a good idea just to kind of get a baseline of where that patient is. And then an MRI is obviously indicated when there's true mechanical symptoms, so locking, buckling, so you are suspecting a meniscal injury, or planning for surgery. So you have instability, you think it's an ACL injury, obviously an MRI is the best way to diagnose that. If the radiographs are normal, but you still have high suspicion of a fracture, get an MRI without contrast. Bone marrow edema will early bone marrow edema. So before a fracture line is present on X-ray, you will be able to see it on MRI. So again, in the setting of trauma, this makes sense, or an acute change in a patient's pathology where they were kind of living at 5 out of 10 pain and then acutely it got worse. You want to make sure that you're ruling out an occult fracture. And then, when radiographs show potential loose bodies, osteochondritis dissecans, or if they've had prior surgeries, an MRI may elucidate more information than just a radiograph alone. So what radiographs should you order? And this is where it's important to be clear. You want weight bearing and you want at least 3 views. So you want an AP view with the patient standing. This is going to give you a really good picture of their joint space, where their patella is sitting. And then you want a lateral view with the knee bent. This is again going to let you see exactly if that patella is high or low, so alta or baja. And then you also want to see what the trochlea look like, what the femoral trochlea look like, but then also what the tibial plateau looks like. So getting that lateral view is very important. And then the sunrise view, merchant's view, skyline view, basically this is with the patient's knees bent and they're coming up looking at the patella. So you're looking at the patella directly sitting in its groove to see if there's patellofemoral maltracking, to see if there's any osteoarthritis in that space. So these are the 3 views. And so head on, you get a good sense. You can see here there's some medial joint line narrowing, a little bit of sclerosis. So this gives you a really good kind of picture. The patella sitting pretty midline, maybe a little bit laterally deviated. So possibly some patellar maltracking here. 60 degrees, a true lateral. Again, the patella is a little bit high riding, a little bit of patella alta. And then you're looking at the trochlea here. So a little bit of dysplasia back here, a little bit of sclerosis over the weight-bearing surface of the tibia. And then the merchant's view or the skyline view. So this is looking at the patella as it's sitting in its groove. So you're looking for joint space. You're looking for whether, it's lateral or medially deviated. You're looking to see if there's any breakdown, of the cartilage. So when you order the x-rays, 3 views, have them weight bearing and often specify that you also want, a sunrise or merchant's view to take a look at the patella. So MRIs are indicated if you're suspicious for a meniscal injury, ligamentous injury, tendon involvement, a chondral defects, or stress reaction. So if your history and exam really point you towards this, then the MRI is more appropriate. Most insurance companies will need an x-ray first. Some cases can be made. And a lot of insurance companies will also want at least 6 weeks of conservative therapy before approving it. So this is where, it looks like a meniscus tear, it smells like a meniscus tear. The x-ray is going to be normal. The MRI would likely show the diagnosis. Is it going to change management? If the patient's not having severe mechanical symptoms, the knee's not locking, they're not falling because it's buckling, then, a course of conservative management before MRI is warranted. The MRI, if it's going to change what you're doing next, like do they need surgery? Do they need injections right away? Then getting the MRI makes sense. If someone has a radiograph and it looks pretty good, but their pain is out of proportion to what you're seeing, getting an MRI can be useful because this would suggest something else is going on. Likely they have a cartilage defect that is just not presenting as joint space narrowing yet on the radiograph, maybe a meniscal injury, maybe an ACL injury that isn't presenting as instability yet. And like I said, true mechanical symptoms, if the patient is buckling and if the leg is getting locked, definitely push for the MRI right away. And if the x-ray is normal and patients have recurrent Baker cysts, that is usually a good sign that there is an intra-articular pathology. Baker cysts result from intra-articular irritation. So meniscus injuries, ligamentous injuries, chondral injuries. So if someone has a Baker cyst and the exam really did not point towards the cause, an MRI could be helpful because there may be something else lingering inside that you're missing. Very rarely does someone have a Baker cyst outside of intra-articular knee pathology. So how do we treat the knee pain? So we're going to wrap up with treatment. So these are the recommendations from our professional societies and the guidelines over the last 5 years or so. And unanimously, everyone kind of talks about weight loss. And I certainly bring weight loss up with my patients, but less in the fact of you're overweight, you need to lose weight, and rather you need to counter um, the weight being put on the joint with muscle. So, I see a lot of patients on GLP-1 inhibitors now, and they're losing a ton of weight, but they're also losing a ton of muscle. And so their joint pain is not getting better because they're weaker. They're not able to stabilize their knees. So even though they've lost 40 pounds, they're no stronger. They're even weaker than they were. So weight loss in and of itself is important, but strengthening is important. And this is where education comes in, talking to the patient about what they have. You have arthritis. It is a degenerative condition. It's not linear, so you're not going to get worse 10% every year. We can slow it down. We can improve the symptoms. And then talking to them about exercise. Most patients will need the guidance of a physical therapist. Exercise in and of itself is great. Walking, swimming, cycling, all really good for the knee if done properly. But strength training, the right muscles around the knee is important. So usually for someone who is exercise naive or exercising but not actually activating the right muscles, I will get them into physical therapy first so that they have someone watching what they're doing to make sure that it's appropriate and safe, and then escalating the exercises as tolerated. Bracing. So, for the most part, a soft sleeve over the knee is not harmful. It can help improve proprioception, so they just have a better awareness of what's happening at the knee. There's a patellar cutout. A lot of times it makes them more aware of patellar tracking. That little bit of compression often helps with pain. Um, and then a lot of times it can also help reduce swelling. So if it's a soft brace, I'm usually not opposed to it. Where the research sort of starts to stagger is the large kind of medial offloader braces or the large hinge braces. If patients are using them too much, they actually start to lose muscle and they start to get atrophy in their VMO and their quads because they're relying on this large, substantial brace instead of engaging their own muscles. So when a patient needs the brace for stability, I'll tell them, no more than 2 hours a day to make sure that they're still engaging their own muscles. So it's not that I say no to braces completely, it's just that I really try and educate them on when to use it. They're going to the grocery store, they're worried about their knee buckling, definitely use it. They're going on a hike with their grandkids, absolutely use it. But all day, every day, I do not encourage it because I want them to make sure that they're still engaging their own muscles. In terms of pharmacological intervention, first and foremost is usually something topical. So a topical diclofenac gel, over the counter like Voltaren 1%, can be helpful. If it's not helpful anymore, sometimes I'll get a compound and I'll have it increased to 3%. And usually there's pretty good local absorption in the knee. So a lot of patients do well, and it's safe. Ultimately, we're always balancing risk and benefits. Oral NSAIDs, certainly if someone comes in with more of an acute knee pain, swelling, and acute aggravation, a short course of 7 to 10 days of an oral anti-inflammatory can be helpful. Again, being mindful of, someone who has CKD, someone who is on anticoagulation. Do they have a history of gastritis? Are they already taking omeprazole? So again, I caution patients about, bleeding risk of GI ulcers, risk of CKD or AKI if they, even if they don't have CKD right away, making sure that they're taking it with food, staying well hydrated, monitoring their blood pressure if they're hypertensive, because there is also a cardiac risk to NSAIDs. So it's generally not something that I'll prescribe for 30 days with 3 refills because I don't want them taking it all the time when they're older with other comorbidities. When they're young and healthy, usually a short course also does the trick. Tylenol, so acetaminophen or paracetamol in the UK, it doesn't seem to be the most effective in treating like osteoarthritis or acute knee pathologies, but it is certainly the safest. So for a lot of patients who cannot tolerate NSAIDs or who cannot take NSAIDs safely, I usually prescribe acetaminophen and I have them take it as a standing dose. If my 75-year-old patient, pain in the knee for a long period of time, end-stage knee arthritis, Taking Tylenol only when needed is usually not going to bring down that pain. If it's 10 out of 10, it's not going to bring it to a zero. If she's taking 1,000 milligrams 3 times a day standing, it usually keeps her pain, closer to a 4 or 5. So it's not gone, but it's much more manageable. So preemptive Tylenol, a standing dose of Tylenol, usually can help kind of bring on more acute episodes. Not really clear indication for tramadol or opioids, because especially osteoarthritis is a chronic condition. Opioids is not going to help long term. Obviously, acutely for an ACL injury, a meniscus injury, and we're trying to just bridge that gap to surgery. Sometimes I will use a week or two of tramadol if I need to for that patient to just make it to surgery. And certainly post-op opioids do have an indication for 3 to 7 days. Duloxetine or SNRIs, seem to help overall with pain, specifically for knee pathology, osteoarthritis, meniscal tears, does not seem to be as helpful. So if I have a patient who, has tried acetaminophen, tried NSAIDs, pain is now kind of out of proportion to what we're seeing on imaging, or it's their legs hurt, their feet hurt, they're having a hard time walking. Um, Sometimes I will add on an SNRI to help with mood and help kind of de-amplify pain overall. And then injections. So obviously we all think about corticosteroids. It's quick, it's easy, it works, it works fast, it's effective, and it's cheap. So it's approved by insurance companies. What we know now, though, is that repetitive dosing of corticosteroids actually breaks down hyaline cartilage. So the more you use, the faster their arthritis will progress. It also weakens the bone, can put you at risk of cortical fractures. So it is something we use sparingly. Used to be, every 3 months, kind of forever until you got a knee replacement. We are more conservative now in using it. We also know that smaller doses work. So a lot of times, our orthopedic surgeon colleagues will give like 80 milligrams and patients feel great. That's a big dose of steroid. I've now cut back and I'm using 10 milligrams of like triamcinolone instead of 80, and I'm still getting great results without the same potential harmful risk to the cartilage. Hyaluronic acid is a very kind of heated topic right now because a lot of the associations are clawing back on their indications. Um, what we do know is it seems to last as long or longer as corticosteroid and does not have the detrimental effect to the joint. So it is recommended in patients who can't tolerate steroids. So if they're diabetic, for instance, poorly controlled HbA1c, you're not going to be wanting to pump them with steroid. It's a great alternative. Or if steroids are just not lasting long enough anymore, hyaluronic acid does seem to last much longer than corticosteroids for the treatment of knee pathologies like meniscal tears and osteoarthritis. Platelet-rich plasma, and then stem cells are certainly buzzwords now. Patients ask about them all the time. They don't really seem to have the bang for the buck. They're very expensive. And we are not seeing that we are regrowing cartilage. What we are doing is producing a collagen fibrin kind of cast over the cartilage, so stabilizing the breakdown. So this helps with pain and inflammation. It may slow progression if you're catching, the patient with mild to moderate arthritis, but we are not regrowing hyaline cartilage. And so it is not reversing the osteoarthritis. It may slow it down, it may delay surgery, but it is not a cure by any means. And then prolotherapy, high concentrations of dextrose, similar to platelet-rich plasma in the sense that we're triggering, an inflammatory response, a healing response. Not great research. Little downside, it's not detrimental to the joint. It's well tolerated. It's much cheaper than PRP, but again, really only used if you've kind of gone through the other treatment plans and it has not helped. So my algorithm usually is, exercise first, focusing on the quads, the hip, the pelvic stabilizers, so the abductors and also the hamstrings. You want to make sure that their IT band is not tight. You want to be stretching those hamstrings out, focusing on patellar tracking. So, what are the mechanics that may be causing that knee to move into varus or valgus? I usually start with something topical. Like I said, standing, Tylenol or PRN if it's not chronic pain, but standing if it is. And then usually, a couple days of an anti-inflammatory, 7 to 10 days for an acute flare. And then I will add on an SNRI if we're looking at a bigger kind of chronic pain syndrome. And like I said, for injections, steroids are quick and fast and cheap, but hyaluronic acid does seem to last longer. So if someone comes in and they've been doing steroids and it's not working as well as it used to, I will usually recommend a hyaluronic acid injection. And platelet-rich plasma injections, we know that dose matters. So a lot of the earlier studies that showed that it didn't work, we were underdosing the platelets. We really need 5 to 10 billion. So getting a baseline platelet, concentrating it to about 7 to 8 times the baseline really is needed to make sure that we're giving it a big enough dose. And then obviously, less severe OA does better than more severe OA. So if you're catching someone with severe osteoarthritis, it likely will not have much clinical improvement. And then something else that we do in physiatry are geniculate nerve blocks or peripheral nerve stimulators of the geniculate nerves. So the geniculate nerves kind of innervate the joint line and the patella. So blocking the nerves that kind of tell the brain that you're having pain, they're giving that painful feedback from the joint mechanoreceptors often helps. So we use this with end-stage arthritis if patients are not candidates for surgery. We even use it for patients who have had knee replacement surgery and they're still having joint line pain from the scar tissue. So it's certainly another tool in the tool belt if someone's having pain and they're either not a candidate for injections or injections are not helping. Kinesiotaping, so basically stabilizing the joint with kind of stretchy tape can help with patellar tracking. The TENS machine, so that can help kind of use up local substance P. Basically, what it's doing is kind of blocking pain signaling or blunting that response. Shockwave therapy uses high energy sound waves to basically stimulate blood flow, perfusion, to the area. It can help loosen up tight IT bands. It can help kind of stimulate muscle contraction. We're seeing much better responses for knee pain with shockwave now. Um, as well. If someone has mostly medial compartment OA, a lateral shoe wedge can be helpful, kind of pushes that joint open a little bit. And then bracing, like we talked about, a medial offloader brace is great for end stage knee OA if in the medial compartment. If they're bone on bone, basically it opens it up. Again, it's big, it's bulky, but does have a role if someone is trying to buy time to surgery or is not a candidate for surgery. And then, like I said before, a soft, patellar cutout sleeve usually is good for just a little bit of edema control and a little bit of proprioceptive feedback. So I know we're just over. I'm going to wrap up with when to refer to a specialist. So sending someone to sport medicine or a PM&R specialist is a good idea if they have not improved with 6 weeks of conservative management. So you've tried ice, you've tried NSAIDs, maybe some Tylenol, you've sent them to physical therapy or given them some stretches or exercises to do at home. If they're just not getting better with your typical conservative treatment, escalating care to a specialist makes sense. If you're considering injections other than cortisone, so hyaluronic acid, PRP, where ultrasound guidance is preferable. So it increases the efficacy and the safety of the injection. Sending them to your sport medicine colleagues can be helpful if you're trying to escalate injection therapy. Or if you want your patient to explore other options. So bracing, shockwave, geniculate nerve blocks, other kind of conservative managements, whether they want to delay surgery or they're not a candidate for surgery, there's a lot more options kind of out there to try other than just, physical therapy, NSAIDs, and cortisone. When to refer to surgery. So when should you send them to orthopedics? So if they have true mechanical symptoms that are not getting better, so the locking and the buckling, because that is suggestive of meniscal injury, and an arthroscopic surgery to just clean up that meniscus can be really helpful in getting the patient back to baseline. If there's radiographic evidence of moderate to severe arthritis and they've failed conservative therapy, so they've tried exercise, they've tried medications, activity modifications, injections, and it's not getting better, then they'd be a good candidate for a joint replacement. And if they're at the point, even if it's moderate arthritis, but the pain is severe and it's limiting their quality of life, it's affecting what they're able to do on a day-to-day, sending them to surgery to at least learn about the options of what a knee replacement would look like is important. And just to be mindful that knee arthroplasty is generally only considered, especially at Sinai, they have quite strict criteria. The patient has to be a non-smoker. They cannot have had a cortisone injection for the last 3 months, and their BMI has to be under 40. So I have a lot of patients where we have done everything, but they're still smoking. Their BMI is still 45, and surgeons will say no. And this is for joint replacement. Obviously, arthroscopy is different. If it's just a quick meniscus repair, that's different. But for knee arthroplasty, you have to try and get your patients to quit smoking, try and have them work to exercising more, to lose some weight, to make them the best candidate for joint replacement.